Cannabis and cannabinoids. At the end of this, students should be able to summarize the acute and chronic effects of cannabis use, differentiate between the effects of THC and CBD, explain the dangers of vaping synthetic cannabinoids, discuss the advantages and disadvantages of cannabinoid-based medicines, describe the regulations of cannabis and cannabinoid-based medicines for sport and athletics, and implement clinical recommendations for advising patients who are prescribed cannabis-based medicine. Cannabis is a plant and contains more than 80 biologically active chemical compounds. One type of cannabis plant is marijuana, which contains the chemical compounds responsible for the high feeling that is often associated with marijuana. These compounds are called cannabinoids. Cannabis contains varying levels of the cannabinoids delta-9 tetrahydrocannabinol, THC, the component responsible for the euphoria and intoxication, and the cannabinol, CBD. Cannabis and its related products are widely available in multiple forms that can be eaten, drunk, smoked, and vaporized. Cannabis that is sold for both recreational and medical purposes contains varying levels of cannabinoids, and products may have inconsistent and uncertain purity. Cannabinol, or CBD, is not psychoactive. There are multiple modes of administration. An example of the interest in cannabis as an early treatment for a variety of disorders is the story of Charlotte Figi, who is described as the girl who is changing the medical marijuana laws across America. Her parents and physicians say that Charlotte experienced a reduction of her epileptic seizures, which were brought on by Dravet syndrome, after her first dose of medical marijuana at 5 years of age. Dravet syndrome is a complex childhood epilepsy disorder that is associated with drug-resistant seizures and a high mortality rate. Among patients with Dravet syndrome, medications based on CBD are reported to have greater reduction in convulsive seizure frequency and higher rates of adverse events compared to a placebo. Media coverage increased demand for Charlotte's Web, the product line named after Fiji, and similar products high in CBD, which has been used to treat epilepsy in toddlers and children. There are 3 distinct types of cannabis plants that exist that are categorized based on morphology, native range, aroma, and subjective psychoactive characteristics. These are Cannabis stevia, or C. stevia, which is the most widely spread variety. It's usually tall and laxly branched and is found in warm lowland regions. Cannabis indica, which are short, bushier plants adaptive to cooler climates and highland environments. And Cannabis ruderalis, which is the informal name for the shorter plants that grow wild in Europe and Central Asia. The National Institutes of Health, or NIH, supports a broad profile of research on cannabinoids and the endocannabinoid system. This research portfolio includes some studies using the whole marijuana plant, but most studies focus on the individual cannabinoid compounds, including CBD. Endocannabinoid systems. Cannabis acts on the brain by binding to cannabinoid receptors to produce a variety of effects. These may include euphoria, intoxication, and memory and motor impairments. These receptors are part of the endocannabinoid system, which affects the formation of brain circuits important for decision-making, mood, and stress response. The endocannabinoid system consists of the endocannabinoids, cannabinoid receptors, and the enzymes that synthesize and degrade endocannabinoids. Many of the effects of the cannabinoids and endocannabinoids are mediated by the 2G protein coupled cannabinoid receptors, CB1 and CB2, although additional receptors may be involved. The CB1 receptor is the most abundant G protein, coupled receptor subtype in the central nervous system. These receptors bind with the THC and mediate many of the psychoactive effects of cannabinoids. There is a particularly high density of CB1 receptors in the basal ganglia, as well as the brain regions, that are the key components of the descending pain pathway and the circuitry for stress, fear, and other tissues and organs of the body. The CB2 receptors, which bind with the CBD, is found to be in the central nervous system, but is mainly distributed in the periphery, with particularly high density on cells and tissues in the immune system. Both CB1 and CB2 couple primarily to inhibit G proteins and are subject to the same pharmacological influences as other G protein couple receptors. The analgesic effects of cannabinoids are facilitated via the endocannabinoid system to the pain pathway of the central and peripheral nervous systems. The primary psychoactive component of cannabis, THC, is rapidly absorbed into the bloodstream following inhalation and extensively metabolized in the liver into multiple metabolites. THC is distributed initially to highly profuse organs, including the brain, heart, liver, and kidneys, with secondary distribution into the adipose tissue because it is highly lipophilic. With chronic daily THC exposure, because of its high lipophilicity, the THC storage in the fat is large, and the rate-limiting step in the THC elimination is the slow release of the stored drug from the tissues, especially the adipose. THC then is excreted in the urine. For individuals who use the drug daily, they may test positive for up to 4 weeks. It is possible to test positive from secondhand exposure, depending on the THC potency, duration, and intensity of the room ventilation. Any positive test is likely to be less than the cutoff level. The behavioral and subjective effects of cannabis are highly dose-dependent. They include euphoria, enhancement of sensory perception, sedation, relaxation, altered perception of time, lack of concentration, impairment of learning and memory, mood changes, panic reaction, paranoia, and impaired psychomotor activity. Other physiological effects may include tachycardia, conjunctival infections, dry mouth and throat, increased appetite, vasodilation, bronchodilation, increased sleep, and analgesia. This spectrum of behavioral effects is unique, preventing classification of the drug as a stimulant, sedative, tranquilizer, or hallucinogen. Although cannabis smoking produces rapid changes in heart rate, pronounced hypotension and dizziness is observed in approximately 25% of people approximately 10 minutes after smoking. Marijuana may impair short-term memory and judgment and distort perception. Concentration, sense of time, fine coordination, depth perception, tracking, and reaction time can be impaired for up to 24 hours, all of which can be hazardous in certain situations, such as driving or participating in contact sports. Marijuana can also affect brain systems that are still maturing throughout young adulthood, so regular use by teens may have negative and long-lasting effects on their cognitive development, putting them at a competitive disadvantage and possibly interfering with their well-being in other ways. Also, contrary to popular belief, marijuana can be addictive, and its use during adolescence may make other forms of problem use or addiction more likely. This is figure 20.1, the short-term effects of cannabis. The adverse effects of cannabis. Advocates cite the safety profile of marijuana in the short term that may have overshadowed some of the longer-term health risks that appear to be associated with even moderate use. Negative health and adverse effects are associated with marijuana use. Because of the nature of how marijuana functions in the brain, death due to overuse is not possible. However, harm from cannabis use has been reported for multiple mental health outcomes, including psychosis, mania, and suicide. There is evidence of structural, functional, and chemical brain changes that may underlie some of the associated risk factors for mental illness. None of this evidence is causal, only associative. The study designs available within humans are limited due to observational cohorts because sufficiently powered randomized controlled trials would not be feasible nor ethical. Nonetheless, athletic trainers should be aware that a variety of health harms are associated with marijuana use and that serious symptoms or adverse events could arise. Clinicians should consider additional preventative measures for their patients, such as referral to their directing physician or behavioral counseling specialists in addiction or dependency treatment. Synthetic cannabinoids are part of the group of drugs called new psychoactive substances. These are human-made, mind-altering drugs, and they yield various psychotic symptoms. Synthetic cannabinoids are human-made, mind-altering chemicals that are either sprayed on shredded plant material, not actual marijuana, so they can be smoked or sold as liquids, to be vaporized or inhaled as e-cigarettes or other devices. Electronic cigarettes or e-cigarettes are also called vapes, e-hookahs, vape pens, tank system, mods, and electronic nicotine delivery systems. Many of these units have Schedule I active chemicals. They have no medical benefit. They're popular among high school and college age students. Unfortunately, these manufacturers evade DEA regulations. The use of e-cigarettes or vaping was introduced into the United States in 2007. This is more popular among the 18 to 30-year-old age group than among older adults. Vaping concentrated marijuana, or dabs, is called dabbing. This practice is reported by 31% of middle school and high school students and 75% of college-age students who vape. Many cases of vape-related lung injury have been reported to the CDC. 91% of these cases required hospitalization, although the specific causes of this outbreak were unknown. Most hospitalized patients reported the use of vaping products that contain THC, with and without nicotine. Based on this concern, the CDC recommends avoiding vaping THC and never manipulating or otherwise tampering with a packaged nicotine product. Cannabidiol, also known as CBD. This is derived from cannabis, stevia plant that is a cannabinoid, most commonly incorporated into medical preparations. CBD was isolated from the cannabis in 1940. Unlike THC, it does not cause psychoactive effects. Advocacy for CBD's therapeutic benefit emanated from medical applications in the experience of recreational marijuana users to a range of disorders, including pain, psychotic disorders, anxiety, depression, and inflammation. Under the Controlled Substances Act, CBD is currently a Schedule I substance because it is chemically a component of the cannabis plant. However, non-clinical and clinical studies are currently being conducted to assess the abuse potential of CBD. Other than approved prescription drugs, CBD products have not been evaluated or approved by the FDA for use as a drug product. This means that for the most CBD products available, the following are unknown: if they are safe and effective to treat particular diseases, what, if any, dosage may be considered safe, how they could interact with other drugs or food, and whether or not they have dangerous side effects or other safety concerns. The three most popular routes of administration for CBD are topical, oral or edible, and sublingual. The mechanism of action for CBD is an agonist for multiple cell surface receptors linked to anti-inflammatory activity that promotes analgesia and opioid-sparing effects. The pharmacokinetics and pharmacodynamic properties of CBD may lead to various adverse events and drug-drug interactions, and there is a lack of quality research in this area. Almost 30% of medical users of CBD have reported side effects commonly associated with THC use, including red eyes, euphoria, and hunger. Medical cannabinoids. These refer to cannabis as a medical therapy to treat disease or alleviate symptoms. Medical cannabinoids can be administered orally, sublingually, or topically, and they can be smoked, inhaled, or mixed with food, or made into a tea. Medical cannabinoids are typically used to treat chronic pain, muscle spasms, and nausea and vomiting associated with cancer treatment. The THC and CBD content varies, and administration is suggested for no more than 4 times per day. Contraindications for the use of medical cannabinoids include pregnancy, mental illness, and cardiac history. Many U.S. states now permit dispensing marijuana for medicinal purposes, and anecdotal evidence is mounting for the efficacy of marijuana-derived compounds. The performance-enhancing effects of a substance are determined if the substance has a medical or other scientific evidence, pharmacological effect, or experience that the substance or method alone or in combination with other substances or methods has the potential to enhance or enhances sports performance. Although cannabis does not have any overt performance-enhancing benefits, in 2021, the World Anti-Doping Agency, or WADA, prohibits the use during competition. According to WADA's prohibited list, substances of abuse are identified as such because they are frequently abused in society outside of the context of sport. Players in the National Football League, or NFL, have enlisted their management to lift the ban on CBD to avoid deterring individual players from using medical marijuana. An argument presented by the players is that when they are treating severe pain secondary to playing football, their choice is either to use an opioid or marijuana. Therefore, medical marijuana should be made an available option. The International Olympic Committee consensus statement on pain in the elite athlete concludes that further research and increased consistency and measures and methods across studies are needed. There is a need to better understand the incidence and prevalence of analgesic medicine used in sports and the benefits and risks of various pharmacological and non-pharmacological treatments, and their combinations for specific pain presentations. Major League Baseball dropped marijuana as a ban and testing in favor of an opioid policy. Cannabis use in athletes has been primarily studied in athletes, elite and collegiate athletes, from an anti-doping or anti-abuse perspective. A review of cannabis use in elite athletes concluded that there was no evidence for use of cannabis as a performance-enhancing drug, and that cannabis may play a role in pain management and concussion-related symptoms. There is an apparent paradox in considering the effects of cannabis on athletic performance. Despite evidence that recreational cannabis may acutely impair psychomotor skills and cognitive function, there is a perception among some athletes that cannabis use may have beneficial effects. The regulation of cannabis use. The legalization of cannabinoid products began with the 2014 Farm Act, which approved legalization of CBD derived from 3 specific sources: industrial hemp cultivation in compliance with this legislation, imported non-psychoactive hemp, and elements of cannabis sativa that were not part of marijuana as defined in the Controlled Substance Act of 1970. Cannabis supplied through regulated dispensaries can be provided as herbal cannabis, cannabis-derived products such as edibles, topicals, and cannabis consumption devices. There is a wide range of state regulations, both legal and medical availability. Cannabis dispensaries can authorize medical purposes. In general, each U.S. state where medical or recreational cannabis is legal has certain criteria for permitted use. These requirements can vary widely and change quickly. In most states that have legalized cannabis, government regulations require producers to use an independent lab to measure the level of cannabinoid in dried cannabis flowers and oils so that the resulting products can be labeled appropriately. The business component of medical marijuana sales is significant. Sales of hemp-based CBD products, not including products derived from cannabis plants, are projected to exceed $1 billion by 2023. By 2027, the global estimate of overall medical marijuana is expected to approach $19 billion US. These products are available through an assortment of consumer sources, ranging from bakeries to gas stations to pharmacies and spas. The manufacturing process, proper dosage, potential side effects, and drug-drug interactions of CBD products have not been scrutinized by the FDA. About 70% of these products have a CBD concentration that is mislabeled. The FDA has concerns about the therapeutic claim for CBD that may mislead the public. In 2019, the FDA issued a warning to a company that was illegally selling unapproved products containing CBD and making unsubstantiated claims that the products treated cancer, Alzheimer's disease, and opioid pain withdrawal. Accurate information regarding CBD concentration is vital for consumer safety. Although they are classified as food products, these products are often used for medical therapeutic purposes. In summary, cannabis use is associated with risk. Younger users may develop acute or chronic health problems. We can mitigate some of this risk with evidence-based information and appropriate discussions. With increases in the recognition of the analgesic effects of cannabis and cannabinoids and their potential utility for pain management, the legalization of cannabis, and the level of cannabinoids prescribed for medicinal purposes, there is a growing need to carefully evaluate the risk-benefit considerations of cannabinoids for the management of pain. It is important for athletic trainers to review the literature regarding pain syndromes. The United States and other countries that have moved towards authorization of medical cannabis and other cannabinoid-based medicines for chronic pain may allow larger scale, empirical, and population-level studies, which will further inform the evidence base. Therefore, the quantity and quality of education and evidence in the clinical experience of prescribers of medical cannabis and the cannabinoid-based medicines will continue to improve. Athletic trainers should try to keep up.